مرحبا وياكم دكتور سنان عدنان، اختصاص جراحة العظام والمفاصل. اليوم راح نتحدث بالقسم الأول من الفصل الثاني اللي هو يشمل الأبدومين and pelvis for year 2 medical students in Iraq and as well anyone interested in the abdominal anatomy for around the world. Now we can see that this is an exploring the abdomen, and we will start for the parts of the abdomen. What are the contents? What is the abdominal wall, and what are the contents of it? Now, as you see, there are many contents here. We will start about the abdominal cavity, the anterolateral abdominal wall, and why we are named like this. We will discuss about some planes and quadrants inside the abdomen that helps us to examine the patient and whether there is a patient have a pain or a mass in each part of the joint or each part of the abdomen or each part of the quadrants. What are muscles and fascia and neurovascular structures and they are related to the abdominal walls. And at last, we have a bonus tip. So keep in touch for this at the end of this lecture. Moving forward to be introduced for the abdomen. And you know the trunk, it has two parts, which is the thorax and the abdomen, as well as the pelvis. So the lower part of the trunk is the abdomen, and the abdominal wall is musculoepineuritic. You know, all muscles in the upper limb, lower limb, head and neck, they have tendons that attach to the bone. Here in the abdomen, we have muscles that attach between themselves. They have aponeurosis. And these aponeuroses forming a structure very important in order to maintain the abdominal wall. The abdominal wall look like a sack, and the contents here, like vegetables or bread, etc., is the abdominal viscera. And viscera, we means that they are the organs of the alimentary system, the GI system. Now you can see in these pictures here, the anteroposterior and the lateral view, that there is a line here in the pelvis, and we will discuss that in later on in next lectures, that the pelvis has the true pelvis, which is here in the dark green color, which is the pelvic brim here, into the perineum. The pelvic brim is an imaginary line between the medial side of acetabulum in both right and left, while the false pelvis in the light green color is the line here, imaginary, between anterior superior iliac spine. And this false pelvis goes up posteriorly up to the third lumbar vertebra here. So the abdominal cavity is inside here and it goes down to the true pelvis, while the false pelvis here is it. So there are many structures, and we will discuss later on for all structures in the viscera in regards whether they are intra-abdominal or retroperitoneal, and we will see these meanings of the retroperitoneal. Now, this is the abdominal cavity, and you see that the diaphragm superiorly, and it goes up to the fourth intercostal space as the diaphragm moves upward and downwards. And inferiorly, the pelvic cavity. The lining inside of these walls of the abdomen is called the peritoneum. And it is a very important structure, which is a serous membrane located at the most of the digestive organs. Now, for clinical subdivisions, if you draw two important lines, this line, the one that is horizontal, is called the subcostal line, which is between the 10th rib from the right and left. You know, any line has two dots. So the dot number 1 is right 10th intercostal space, and here is the 10th intercostal space on the left. So we have a line here. While this line, another one, is called intertubercular line between the tubercles of ileum, the right and left as well. The other perpendicular lines, vertical lines, are here is the mid-inguinal which is very hard to know between the, the inguinal ligament between anterior superior iliac spine to the pubic tubercle. But you have a fixed point, which is the midiclavicular. Okay, so the clavicle, if you have got it in the midiclavicular point and draw a perpendicular line on this one, the subcostal plane, and then you go down and immediately it goes into the midinguinal point. Now we have nine regions inside the abdomen. We can describe them as well. So you can see in the middle, this is umbilical region, or called the gastric region. Above it, epigastric, below it, hypogastric, or sometimes we called it pubic region because it is related to symphysis pubis. While these two upper part called the hypochondrial or hypochondrial region or hypochondrium without region. So we have right and left. And here in the middle, right and left flanks. Flank is a general English word, and we can see it is a lumbar region because it is related to the lumbar part posteriorly. And the last here, we have another two here. They are the groin region or inguinal region because they are related to the inguinal ligament. So if the patient has got a right hypochondrial pain, which means we are dealing with this subject, with this area, or there is an epigastric mass, we are dealing here, or right flank abdominal pain, which is here, and so forth. A very common example is that appendicitis. If patient has right groin pain, started from epigastric region into the right hypochondrial pain, and there is a groin pain or right tenderness of the groin, all right? So these are the clinical terminology. We can see that. Now, all of these things are suggested here with the quadrants, 4 quadrants here also. We have transumbilical plane, and we have the median plane, and the median plane goes like this. I will draw it here from the xiphisternum down to the pubic symphysis. And we have got also transumbilical plane. So we have right upper, left upper, right lower, left lower. So these are the quadrants here. Now, if you can see that there are walls and boundaries, and you know that the abdominal wall, we call it here the anterolateral because of the muscles of the abdominal wall, and especially that these muscles going from the flanks and the upper part and then inserted into aponeuroses, and each of these aponeuroses are attached together in the midline, which is formed the linea alba, which is the white line. And then you can see the boundaries from the 7th to 10th rib, costal surface, the xiphisternal process, and inferiorly by the inguinal ligament and the pelvic bones. Now, the skin and fascia, they are important because every surgeon in the abdomen, he should or she should know the layers of the skin and fascia. And if you can see that, the first is the skin, and we have the subcutaneous fatty layer, the yellow one, and it is called Camper's fascia. And we have this one is a dark purple. It's a deep membranous fascia. We called it Scarpa fascia. And there are 3 muscles. They are the investing fasciae of the abdominal muscle, namely external, internal oblique, and transversus abdominis, the last one. And after transversus abdominis, an important fascia, which is called transversalis fascia. Sometimes we call it endo-abdominal fascia. But transversalis fascia is more common term, is the last fascia that covers the anterior abdominal wall. After it, there is an extraperitoneal fat because this line, which is a dark white, I think, yeah, or gray, it's the parietal peritoneum. Parietal peritoneum is the lining membrane of all viscera inside the abdomen. Like you see, this is the skin again. Camper's fascia is here, and this is the scarpa's fascia below it. And this line is from the xivisternum to the symphysis pubis. It's not a line, actually, it's a tissue which forms the aponeurosis of all three muscles called linea alba, which means in Latin white line. And after the scarpas, there are three layers of muscles: external oblique, internal oblique, transversus abdominis, and we have the transversalis fascia. This one is in green, the transversalis fascia. And below it, we have the extraperitoneal fascia and then the parietal peritoneum. Now, all these things have been discussed here in the picture. You can read it here or here. So let's moving on. We will see many things interesting that we will do it and know it. Again, we have the deep fascia and other fascias here. Now, how about the muscles? And we said before the external oblique, and this is the external oblique muscle. And you know that the muscle is that originated here from the part of the thorax. It's with the latissimus dorsi posteriorly and the abdominal part of pectoralis major, if you remember it. And if you have got seen that the direction of fibers of external oblique looks like when you put your hand in your pocket and the fingers are directed downwards here. So these are the fibers of muscles. And you know that the insertion here in the linea alba with its large aponeurosis here. This is the external oblique from the lateral side, and you can see that the latissimus dorsi is there, and serratus anterior is here, as well as the pectoralis major. So they are shared common origin with the external obliquus muscle. In regard of internal oblique, and let's see this picture, and you can see now the internal oblique muscle, they have many directions of the fibers. Most of these fibers, they are like this, going upwards, unlike the external oblique. Like you put your hand in your finger, and you see that external oblique muscle had been cut in order to see the internal oblique muscle. An internal oblique muscle is that here we got it in this picture. It's almost like the transverse, but you have seen its directions there. So they are perpendicular to the lower fibers and parallel to those of external oblique. Almost the lower fibers are parallel to external oblique, but major part is in the upper fibers. They are not parallel with external oblique muscle. Now, the exception is that the transversus abdominis, they are horizontally directed. So these muscles are according to the direction, and they are named. And if you look at the origin insertion of each, you also know that the action is there in order to compress, support abdominal viscera, and major function is that flexion and rotation of the trunk, like you have an abdominal push-ups, okay? So while the innervation is very easy to remember, I need you to know about the innervation of external oblique is 7-11 anterior rami. So T7 to 11. While those from internal oblique to rectus, they have 7-11 associated with subcostal nerve. Okay, we have subcostal nerve there, which is T12. But remember that 7-11 and subcostal, which is T12, okay? And we have got the transversus abdominis, rectus, and internal oblique associated with L1. So from T7 to L1 nerve roots, they are supplying these muscles. Now, what about the vertical muscles, which is rectus and pyramidalis? Know that the rectus abdominis muscle have been seen here in this picture. It's faint one. And it is the formation of six packs. The athletes have said we need doing a rectus muscle strengthening. So it's a strap-like and it's mostly enclosed in the rectus sheath. There's another sheath there. And the muscle fibers of the rectus do not run in the length of the muscle. They are run in between three or more tendinous intersections. And they are typically located at the level of the civic-sternal process, and you will see it here in this picture. Now you can now examine the muscle, and this is from the civic-sternum, and then there are tendinous intersection. They have got us the six packs. What is important actually is that the lining sheath, these muscles we have said before, and they have investing fascia in each of them, and it's aponeurosis. Okay, so here of the muscle of the rectus, it is not with that of the sheath of them. Look at this nice picture. Now, the colored one is the external oblique, and you can see now here we have got the green one is the sheath, and also the yellow of the internal oblique, the blue of the transversus abdominis. Now, these things here are called the rectus sheath because because these sheaths not only enclosing the muscles of the abdomen, the three one, but also encloses the rectus abdominis from the right and left, like you see here. Look at this very closely. Now I will make it larger. Now, rectus abdominis is here, and it is enclosed from posterior and anterior by all three sheaths. Okay? Remember that the black color is called transversalis fascia. It is the layer behind the transversus abdominis muscle, all right? So the rectus sheath is enclosed by transversalis fascia posteriorly, and the sheaths of the external and internal obliquus muscles. Okay, and this is invagination here is called the linea alba, like we see before. So the aponeurosis of external, internal oblique, anteriorly to rectus sheath, and we have the part of the rectus sheath posterior to rectus abdominis muscle, which is the here internal oblique and transversus fascia and transversalis fascia, sorry. All right. Now there is an exception, and it is very important exception here. In this picture, you can see the rectus abdominis muscle posteriorly only. There is a posterior wall of the rectus sheath, all right? And we see that the sheath is going from the transversalis fascia as well as the rectus sheath. While here, below the arcuate line, in the last quarter of the rectus abdominis, there is no thing called rectus sheath. It's only transversalis fascia, okay? And let's go back to see it here in this nice picture again. I'm sorry. Let's enlarge this one. Yeah, okay. Now this is below arcuate line. If you can see that the rectus sheath, all three muscles aponeurosis are anterior to rectus abdominis muscle. The sheath is anterior now to the rectus abdominis muscle. This is the rectus sheath. While only posteriorly covering the muscle is the transversalis fascia in a black color. Okay, now what is the arcuate line? It is the line here that is the end of the rectus sheath posteriorly. Okay. Here we got superior to arcuate line, inferior to arcuate line, and this is the arcuate line in detail. So you can read it slowly. And if you have any questions, please write it down And if you need the PDF part, you go down for the description below and hit the click on the Telegram channel, and you will get the PDF part. So we are talked about rectus sheath and many things there inside. So you know, a rectus sheath, it's a sheath like a sack. Inside it, there are vegetables and fruits. What are the vegetables? What are the fruits? First of all, is rectus abdominis muscle and pyramidalis muscles, these muscles of the vertical part. Now, the second thing is that there are two arteries. They are very important, which are simply called superior and inferior epigastric arteries. The superior epigastric artery comes as a termination of internal thoracic, while inferior epigastric artery, it comes from the external iliac artery. Again, if there are arteries, there are veins and lymphatic vessels. And don't forget about the nerves. The nerves, 7 to 12, distal portion, anterior rami, 7-11 plus subcostal. These are supplying muscles and as well the overlying skin. Now, let's go forward for the ligaments. We finished the muscles, the neurovascular bundles, the sheaths inside the muscles or enclosing the muscles. Now, the ligaments supporting these muscles are inguinal ligaments. Everyone will know it. It's from the anterior superior iliac spine into the pubic tubercle, and this is the inguinal ligament. Look at the aponeurosis of external oblique muscle. This aponeurosis here, just above the ligament, and it's vagining and turned around itself in order to make a turf or a tunnel. Okay? And this is very thick part here. And below the inguinal canal, inguinal ligament, you will see the vessels of external iliac artery will become the femoral artery and vein as well. Now there is here, apart from this inguinal ligament, a semilunar, a crescent, a crescent-shaped extension from this part, just medial, just lateral to the pubic tubercle, and it goes from medial end of the inguinal ligament backward to the pectineal bone. This is called lacunar ligament. And this is a very nice picture to see that the lacunar ligament is there. This is the inguinal ligament. And you can see the lacunar ligament, how it is curved, and then it is attached to the pectineal line. This is called the pectineal line, where the true pelvis entry. This is the pelvic brim. Okay. The pectineal line also have a ligament, which is called either pectineal ligament, or you can say it is a Cooper's ligament. Okay, so if you got this view, which means that this is the internal side of abdominal wall, like you are going inside the abdomen and you are looking at the window, okay? The abdominal wall, they have windows. So we are going inside the abdomen and we are looking from our inside to out, which is, this is the internal surface of the abdominal wall. Internal surface of the abdominal wall have very interesting features, and let's draw these features. Now, it covers with the transversalis fascia. This is all the parietal peritoneum. This is the hazy line, hazy thing here. This part, and in front of it, anteriorly, is the transversalis fascia. Okay. Also, we have the extraperitoneal fat pad and parietal peritoneum. But there are very important folds in this walls or in these windows that we are seeing. The first one is one single median umbilical fold. It goes from the apex of the urinary bladder here. This is the urinary bladder. And going up into the umbilicus, where the umbilicus, they have round ligaments and paraumbilical veins. They are rudimentary arteries that were present when we are fetus. Okay. And we have also in the medial umbilical ligament, which is the remnant here, the medial umbilical ligament inside the fold, which is a remnant of the urachus that join the apex of the fetal bladder to the umbilicus. Okay, what's again here is that there are two another folds here. This is the median umbilical in the red, okay? It's going up for the blue one. This is the medial umbilical fold, medial. This is median. This is medial. And we have also the lateral umbilical fold. Okay, so these are the folds of the internal surface of the wall. And you can see that here is the occluded part of umbilical artery, and the lateral is the medial umbilical, lateral to the medial umbilical fold is the lateral umbilical fold, which is covering the inferior epigastric artery. This is very important here because here we have inferior epigastric vessels. So if you got an incision there, it will bleed. Okay. Now, we are going forward for something more interesting, which is the bonus tips. Now, the bonus tips is there. If you got this part of the folds, and you know that, again, I will catch it with the red one. Okay. Let's choose a red line. And we choose it. We said before that this is the median umbilical fold into the apex of the bladder. This is the medial umbilical fold. It was the umbilical artery. And this is the lateral umbilical fold. Now, these forming what is called the soft tissue fossa. The supravesical, vesical, it means that, this word, it means that it is a urinary bladder. Supravesical fossa, which is between the median and medial. This is number one, okay? And this is a reflect of the anterior abdominal wall into the bladder. The medial inguinal fossa here, which is called the inguinal triangle. It lies here, number two, between the medial and lateral umbilical folds, and also commonly called the umbilical or inguinal triangle, or by the name of the scientists is Hasselbalch triangle. And they are direct inguinal hernia locations. So the lateral inguinal fossa is anything lateral to the lateral umbilical fold, which is number three here. And you have here the deep inguinal ring, just lateral to the vessels, okay? And this is the indirect inguinal hernia. Okay, these are the clinical importance of the anatomy. And then we need to know about surgical anatomy. This is a surgical tip. If you got an incision or you do an incision inside the abdomen, when you are need to suture it, don't suture only the skin or all together. You have to be in layer by layer, which this in surgery, we called it the watertight sutures, which means that never ever put the water or fluid goes down from the skin inside the abdomen or vice versa. Now you can see here in this picture that our thread in A, we are dealing with this. This is the linea alba, and these are the recti, rectus right and left. And you can see the threads are going there in order to close it very tightly. And then we are closing the skin and subcutaneous tissue as well. In order to see it in a cross section, you will see that these muscles are here. And if you lift this one down without suturing it, this will cause to make the fluid upward, and there will be problems or complications of the skin incision, like a urine or ruptured urethra. However, if there is in this picture, this is also a very nice picture here, and you can see this is the lateral aspect of the abdominal wall. like you can see here, the aponeurosis of internal and external. And this is the membranous part, and this is very important. The membranous part, which is scarpa's fascia. And this is the here scarpa fascia, and this is the skin. Now, you can see that scarpa fascia is stopped at the level of the symphysis pubis. And then there is a hitch or hook. Then it will be as fascia lata of the thigh. Okay, so any fluid is there will go down because of the gravity. So you need to fix this up because the membranous layer here, scarpas, you need to suture it like this very tightly, and you left nothing opened because as you can see, nothing goes up. If the urine comes past this part or any fluid, it will not goes down to the thigh because we have the superior ramus of a pubic bone. And there is no connection between the thigh fascia and abdominal fascia. So if you got this one, a leak part of the thread, and you don't suture it like this, fluid will goes out of the skin. And here we are. The last tip is that we are choosing an incision, and there are two types of surgery. The first one is here, which is the ordinary. We have got an incision inside the abdomen, and you know that they depends on rules. The skin incision should allow adequate exposure. You need to figure out the exposure which is completely done and possible cosmetic effect is best possible cosmesis effect, because ugly skin will be not cosmetically appealing, especially in females and males as well. Depend on the type of operation, location of organ, bony cartilaginous boundaries. Be aware about that because you know that this line, for example, is just below the costal surface, not above it, not transverse. It is not good. Avoid any motor nerves, especially the motor nerves. When we are dealing with the internal, external oblique, we are not make a bizarre incision or transverse here because it will cut the nerves. And instead of transecting these muscles, the transecting muscles may cause irreversible necrosis and death. The surgeon is splitting the muscles between their fibers using the fingers. Now, rectus abdominis is an exception. From this rule, this part of the rule, which is number 4, the exception is rectus abdominis because the muscle fibers are short and you can transect it from transversely, and then you go up, you go here and there. So these are the rules in choosing an incision for surgery, and these are the lines of the surgery. This is not for your year, actually, it is for advanced year, but only to imagine yourself in the abdomen, and then you are going from the midline. This is a midline incision, and this is near the midline, which is called left paramedian or right paramedian. Rarely we use the right paramedian. And here is the oblique one is the subcostal incision. And here is called the McBurney point. And you can see this scale. It looks like a scale by centimeters. And actually, this is for the general surgeons. And when we will study the general surgery points, you can see that the umbilicus to the anterior superior iliac spine have got 3/3. The lateral third is that called McBurney point, which is actually the indicator for pain when there is appendicitis. So if the incision is got obliquely like this downward, it is called gridiron. And if it is transversely like this very small one, which is called the transverse abdominal incision. Last but not least, we have the yellow incision suprapubic, which is called finisteal incision, and finisteal or finisteal, sometimes they actually, it is finisteal. So the phalansteal incision is very important and well known for cesarean section in order to extract the babies. Okay, now these are the tips for the surgery, and here we got, the abdominal wall. They have functions and actions there. So mainly they are supporting the organs, they are protecting the viscera and compressing the viscera as well in order to for defecation or urination, vomiting, childbirth, etc. And these are very important in our life as well as in compressing these in order to maintain respiration, like when we are blowing the air from inside the abdomen, like when you are have a deep breath, a deep breath, and then you blow away forcefully. Okay, so when you are blowing away the forcefully, the diaphragm will be overrated there, and it will go upward, and abdominal wall will be contracting in order to blow the air forcefully from out of your mouth. Now, the last thing is that in your vascular supply, and this is very simple one, you remember that 7-11, the thoracoabdominal, and you have a subcostal, T12, and L1 has two names of nerves, which is iliohypogastric, ilioinguinal. These names are important, and this is important too because these nerves not only supply the muscles, but also supplying the skin. And for the skin, remember that around the sternum is C6, around umbilicus is T10, and near, not around, near the pubic symphysis is L1 nerve root. So in between, you can imagine that what would happen. 7, 8, 9, 10, 11, and 12. So you have to remember these three dots, which will uh, highlight this L1, T10 around the umbilicus, and T6 around the xiphostomal process. Below it, it will be 7. So these are important to know about the skin supply. And these are the nerves and how they are going up and down or the courses of them. Now, if you need to know, these are the arteries. The arteries are only, you try to remember the origin, that the internal thoracic, the aorta, and external iliac, and last, the femoral artery. And each has got two. Internal thoracic has got musculophrenic, superior epigastric. Aorta has got two. Actually, they are three. I would like to say they are three. 10, 11, and 12 posterior intercostal. You have got external iliac, the inferior epigastric, deep circumflex iliac. The femoral artery has got two also, superficial circumflex and superficial epigastric. However, if you like to know how do they work and without going back into the distribution and courses, you need to remember this one. This is very easy because superficially and deep, superficial muscles and superficial area, part of the abdominal wall, superior and inferior. And the deep also have superior lateral and inferior. So from superior superficial, you can see that the supply is musculophrenic, which is part of the internal thoracic artery. Inferiorly, we have this one is supplied by medially superficial epigastric artery, laterally superficial circumflex iliac artery. They are both from the femoral artery. And in the deeper part, you can see that the superior is supplied by superior epigastric, lateral by the 10, 11, and 12, inferior by inferior epigastric and deep circumflex iliac. This one is easier. I need you to focus on it and compare it with this figure. Now, regarding the anastomosis of veins, they are very many, and you can see that the superficial epigastric femoral vein and the lateral thoracic to the axillary vein, and then goes to the thoracoepigastric. They are provide potential collateral pathway for blood. Normally, they are going to inferior vena cava and then to the heart. Regarding the lymphatics, transumbilical line, you know this line. So anything above it will goes upward and below it goes downward. So we have superficial and deep lymphatics. They are accompanied the subcutaneous veins there, and the deep lymphatics accompanied the external iliac. So in the upcoming will be the practical abdominal wall, including the inguinal canal. So this lecture 1 and lecture 2 is the inguinal canal or inguinal region. After that, there will be an upcoming practical abdominal wall for cadaver course. Now, if you got like this picture, you need it for a PDF, please go down in the description below, hit the click on the Telegram and upload the lectures. Thank you very much. Have a nice day.